Good morning, everyone. My name's Rob Music. I'm the Chief Executive of the Migraine Trust, and really delighted to see that so many people have joined today and have signed up for this. Firstly, before anything, I'd just like to introduce the panel that we've got. I'm really grateful for you all for coming along and supporting. So we've got Phillipa Williams, who's the Strategy Director at Claremont, and Phillipa's going to be sort of talking us through some of the key findings and the themes from the research and the report. We've got Abigail Cabaru, who's going to share her story after Phillipa, and Abigail's been a wonderful supporter of the Migraine Trust for some time, and Abigail, really grateful to you. We've got Dr. Niran Nimalananthan. Niran is the National Clinical Director for Neurology at NHS England, and Niran is joining the panel. And we've got Kate Sanger, who is the Head of Policy and Communications at the Migraine Trust. As we're going through, and please start thinking, there may be some things already, but if you could send in your questions into the chat, and then colleagues will be looking at those and monitoring those, and we'll get those questions out once the various presentations have taken place. Feels like this, for me, this feels like this is a really important day. But this is the first research that has been undertaken to really try and explore the piece around gender, ethnicity, and social grade, and how in terms of migraine and how it shapes their experience. You'll hear soon more from Phillipa, but it reveals how identity and how perception influence not only interaction within the health system, but the ability to stay in work, the likelihood of disclosure, whether individual people feel able to speak openly about their condition in their professional, medical, or even social settings. So you'll hear from Phillipa quite soon. I just wanted to, I guess, before we start that, give it a little bit of background in terms of people with migraine and where they're currently feeling. So thank you again, I think, for joining us. The first bit I think it's quite important to get across is that we're talking about something that is enormously common. And I think it surprises many people when they see some of these numbers. We're talking about a condition that affects 1 in 7 people in the UK, 1 billion people around the world, and it's the second largest cause of disability, and it's quite extraordinary, really, that despite being so common, and I still find these numbers quite staggering when I see them, that there are still too many people who don't really recognise or understand the size of the problem, take notice of it, or take it seriously, and that can lead to a huge amount of despair and frustration for people with migraine, particularly when told something like it's just a headache, and when it is very, very much more than that. And forgive me, my slide doesn't want to behave. There we go. This was a fairly recent word cloud, and it shows that we've got some way to go to, I guess, reduce the impact that migraine has on people's lives. That too many people they're still struggling. They're struggling with their physical health, with their mental health, with their care, their feelings of uncertainty and isolation. And people regularly tell us that receiving a correct diagnosis can be time consuming, it could be stressful, it can be difficult, but quite often you can wait many years to get that right treatment, that right care. I remember I was in a meeting a while ago with some people living with migraine, and it was really upsetting to hear that people were saying they feel like they're a burden, that they feel like they're a nuisance, just even asking for help, that they feel quite invisible. That a community survey that we ran, which 1,800 people responded to, so the feedback was that less than a third said they were satisfied with their care, but they just want to be treated as partners in that care. And then alongside that, with the challenges of the patient journey, right care identified that the underdiagnosis, that the undertreatment of migraine, along with the poor public perception of migraine, and also healthcare professional perception of migraine, has led to really large numbers visiting A&E or being referred to outpatient neurology services for potentially unnecessary investigations and treatment. I think that the data on this slide sort of backs that up, that we're seeing numbers going up, and that's quite concerning. 18% up in the last year, 91% up since 2021, and nearly 300% in the last 10 years. That's really quite significant numbers. But we also know that for many, the severity, the frequency of attacks can impact on a wide range of people's lives. And the data that's on this slide is a mixture of data from some of Migraine Trust surveys, but also the MyNeuro survey, which is the largest UK-wide survey of people living with a neurological condition. Really, really powerful data. And we see this regularly, we hear it through our services. And really sad to see the one but bottom bullet, that nearly a third of people have thoughts about suicide. And we know that around about 7%, that's quite frequently. Another key area is around work. We spend the majority of our time working, and for many with migraine, that's difficult. The data here is from a range of surveys that the charity has run. And alongside this, 43% of people living with migraine said they were impacted financially because of how it affected their career, their employment status, and that increased to nearly 60% if you live with chronic migraine. And I think that last bullet is particularly concerning. This is from research we launched during Migraine Awareness Week in September this year. Too many managers, really worrying data, would be concerned about hiring somebody who lives with migraine. And it goes back to this poor understanding, this myth and the stigma around migraine that really has got to be broken down. And there was research by the Work Foundation that estimated there's around about 43 million days a year lost from work. And pro bono work done for the charity showed that the cost of productivity through absenteeism and presenteeism is about £9 billion, sorry. But if you could just improve that care pathway by 10%, you'd save about £1 billion a year. And that's huge, really, really significant. And really 10% is probably a minimum target and should be much more. But these numbers are really important, that when the charity wants to speak to civil servants and governments, it's the money piece that really, really talks. And we need to try and get that across, how things need to be improved. So the charity's vision is here. Our vision is for everybody. But unless we know how people experience migraine, how can we build those pathways and those structures that support their needs? And that's why the data from this research is so important, because there have been such huge gaps in understanding and knowledge of different groups of people who live with migraine. So I'm going to stop now, and I'm going to hand you over to Phillipa to talk through the research.
Thanks so much, Rob. I've now got that wonderful task of sharing my screen. Can you see that? Rob, can you give me a yes or a no?
No. Yes.
Yes, marvellous. Thank you. So the first thing to say before we get into the detail is that this work was funded by TV UK Limited, but they had no involvement in the production, the final content, or the outputs of the work. So when we first started working with Kate and Rob and the team at the Migraine Trust, and we first started talking about the need to look at this kind of broader experience of migraine, we started by asking ourselves the question, well, what has already been done? What research is there already out there? And as this kind of slide tries to allude to, there was very little. So there is, when you're thinking about the kind of impact of gender, ethnicity and social grade, looking at existing literature and, We did a literature review. There may be people that are part of this webinar that know of additional pieces of research that have been done that we weren't aware of. Please do share them. What we could see was that there was some literature out there that talks about the interrelationship between, in particular, gender and migraine, the impact on family relationships and particularly caring roles, and the challenge both for women and men within that. There's also research that talks about kind of gender in relationship to productivity and the ability to stay in work, and this really interesting element with migraine of presenteeism often being a challenge over absenteeism. And there's also some work looking at accessing of healthcare, and particularly, as we see in lots of other conditions, kind of men being slightly less willing to seek help and support for migraine in comparison to women. But I think, as a kind of literature review back from 2022 showed, is that there is very limited research that looks at the migraine experience, both from diagnosis, management and support, that really takes into account of many other characteristics. And there were really obvious gaps for us. So when we were looking particularly at ethnicity, we found no studies that looked at migraine experience on the impact of migraine on relationships or family life or workplace that's linked to ethnicity. We found a study in the States that was done looking at healthcare experiences of people with migraine within the kind of context of their ethnicity through that lens, but not a significant amount of research. And when we started to look at social grade, there was very, very limited amount of work that had been done. There was some indication that that there was a link, that there could be higher prevalence amongst those in lower socioeconomic groups, and a suggestion that could be linked to the impact on the ability to work and therefore what that does to your financial capability, but very, very limited. And so this work was really about trying to build a broad knowledge base, looking at three things: ethnicity, gender, and social grade, and how they impact the experience of migraine. And we classified the experience of migraine as the impact on your kind of personal life, so your relationships, your friends and family, your ability to kind of be part of your community, on your ability to work and your experience of work, and then also your experience with the health system and healthcare professionals. And really our sort of aim was to build a foundational piece of work onto which other pieces can be built going forward. And you'll see that as I talk through this, quite a kind of broad brush piece of activity. The methodology we used was, as I've talked about, literature review, and then we did an analysis of a number of open online migraine forums. We then did a quantitative study, online research, 2,000 people living with self-reported migraine, and then with boosts of people who would categorise themselves as Black, Asian and mixed ethnicities. And then we moved into qualitative research, so 18 into 60-minute one-to-one interviews, which was weighted towards women, but did include men, all of a low socioeconomic grade, and that was based on the findings from the quantitative work, and then looking at trying to get deeper into ethnicity rather than looking at those kind of quite unhelpful broad brush groups that we had in the quant. So across white British, Bangladeshi, Pakistani, Southeast Asian, Black Caribbean, Black African and Black British groups, and then analysed it all, which we're going to present to you today. We should say that there are obviously, as always, limitations with this research, and they are the fact that, one, the quantitative work was done online, so obviously that excludes people who are not comfortable being part of online work or maybe digitally excluded. The ethnicity samples in the quant work were based on kind of big, broad brush ethnicity categorization, which, as many people on the call will know, is not always, gives you too much of a kind of broad brush view, which is why in the qualitative work we then looked at kind of country of origin in more detail. Thirdly, as we know, none of these kind of parts of us define who we are individually. So we have tried through the qualitative work to look at more of the intersectional analysis. but with the quant work, because the sample size, that was more challenging. And I think the final thing to say is that this work is really about finding some broad themes and conclusions. But as Claremont and as the Migraine Trust, we would really love to be able to take this work forward and kind of look in much greater detail at some of the themes that have come forward. So enough about the background. Let's get into what we found. So the kind of overarching thing that I'm going to talk to you about today is this. As many of you on this call will probably know already, migraine is not just a medical, clinical thing. It is deeply social, and it has a significant economic impact on individuals. And really what I think is particularly interesting about migraine and what this work shows is that because it is invisible, in order to access help and support, you have to be able to share what is going on for you. You have to be able to disclose. And really what I think this work is showing is that how you feel that you are perceived by others, how trusted you feel, how comfortable you feel, how safe you feel, really impacts your willingness to disclose your migraine symptoms, how it impacts you, and to seek help. And part of what influences how we are perceived by others is shaped by our gender, by our social grade, and by our ethnicity. And I think what we've also saw, and what particularly came through the qualitative work, is when people do have kind of plucked up that courage to disclose, if they're met with a lack of understanding, when treatment options can feel quite limited, when adaptations for people with migraine can feel quite limited, almost that experience kind of reaffirms their original concerns about disclosure and therefore makes them more entrenched. And so you get into this kind of vicious cycle. And together they all combine to keep migraine invisible, dismissed, and ignored, and a profound impact on people's well-being. So if that's the kind of big picture thing that we want to propose as part of this work, there's kind of 5 overarching insights that I'm going to go through in the conversation. And I'm going to start with this one: migraine feeling widely misunderstood and trivialized. So particularly in our qualitative work, but it also comes through in the quant work, that people across those 3 areas that I've talked about, their home and the community, their work and healthcare settings, people felt consistently kind of dismissed and invalidated around their experiences. And that misunderstanding, that kind of sense of it's just a headache, that kind of sense of, just get on with it, the challenges of really understanding the complexity of migraine, and the challenges of really being able to understand what is going on for other people, made it really challenging for people to explain their experiences, and also that they felt the kind of sense of duty themselves to have to share that. And one other thing that I think was particularly interesting is for those people who'd lived in families where other generations had had a migraine, sometimes that's positive in that it can create this kind of supportive environment, but sometimes what it can do is kind of normalize migraine or perpetuate misinformation. And I suppose and there's a number of quotes there that just sum up that experience. So when people can't fix it, they don't know how to behave, so they just sort of back off, which is obviously really prevalent in other chronic conditions as well. You just get a headache, get over it. I just felt like the GP was basically saying, stop wasting my time for just a headache. If you have to have experienced it to be able to understand it. And what's interesting is when we looked at in the quant work, on this chart, the sort of teal colour is people who would report as being from an Asian background. The darker blue is from people who'd report from being from a Black background. You can see that particularly those from an Asian background felt more embarrassed, found it more difficult to explain, worried about not being believed, worried about stigma. Those from a Black background felt sort of worried that they would be believed, and again found it challenging to sort of explain what was going on for them. And that is also in some ways repeated from those who from a lower socioeconomic background. So in comparison to those who are of a high socioeconomic background, group said that they felt that others wouldn't be interested, don't want to make a fuss, worried that people wouldn't believe me. Moving on to disclosure, and what I think we saw really strongly through this work is a sense that disclosure and telling people about migraine experience, particularly in a work context, felt really risky. And we saw evidence of people actively concealing their migraine for fear of being seen as weak or unprofessional, but also for fear of losing their jobs. And I'll show you some statistics that really back that up in a second. They felt that it could lead to job loss, and particularly if they were in a safety critical role. So we spoke to people who were in hospital settings, to people who were in transport settings, and that kind of fear of, if I disclose, what will that do to me? And bearing in mind, as I said, the qualitative work was undertaken with a sample of people only from low socioeconomic backgrounds who tended to be in jobs that felt more vulnerable with a less of a safety net. This kind of sense of feeling replaceable came through very strongly. And we also saw some level of I suppose, gender stereotyping playing out. So men feared appearing weak in the workplace, worried about, or much more likely to worry about what their colleagues would think of them. And women feared being seen as kind of unreliable or dramatic, had a higher fear of discrimination. And men also described kind of a cultural pressure about expressing pain, and kind of some people linked that non-disclosure to the desire for them to kind of demonstrate their strength and their resilience. It's really interesting. I worry I would be seen as a problem employee. Now, these samples are quite low because we've done age breaks across ethnicity and across social grade and gender. But if you kind of just sort of zoom in and look at them, I think particularly this column here, which talks about how do you think your career prospects have been affected by your migraine? You can see that for younger men, they feel that they have it's prevented them from applying for certain jobs. They think they've been denied promotion. They think they've been sacked and dismissed. For women, similar pattern. For those who, and similarly for those who are within a CTDE role, on that kind of older group fear a little bit differently. And the reasons why they're reluctant to kind of disclose is that sense of, impact on my relationships with co-workers, but also this fear of not being taken seriously, of discrimination, fear that I will be judged, fear that, and also a kind of sense that, like, what could actually realistically be done. And I've spoken about this around discrimination, and this is particularly interesting. So when looked at it from an ethnicity background, there's a sense again for those from Black heritage, much more likely to fear and report feeling a fear of discrimination around disclosure. Those from mixed ethnicity backgrounds, much more likely to feel not being taken seriously, concerned about confidentiality, concerned about judgment of their co-workers, and those are reflected also from the Asian sample as well in comparison to the white groups. So thirdly, self-management is the norm and not the preference. And I think across the work, what we saw was that a kind of sense of overwhelmingly people feeling that they had to cope with their migraine alone, and that they developed their own coping strategies because they felt that what they didn't get is what they needed from their healthcare professionals. And that might be using online forums, that might be over the counter meds, that might be data piercings, that might be just kind of getting on with it, or people feeling that, they knew their migraine themselves well enough to be able to manage. What the quant research shows is that those from Asian backgrounds had a significantly more negative healthcare professional experience, and those from Black backgrounds feeling that they had to really convince their healthcare professional of their condition in comparison to white groups. And what's also interesting is for those whose migraine was more severe, they felt like their ethnicity, their gender, their class, or their age had much more negatively affected how they were treated by healthcare professionals. And this kind of shows what I was talking about before of that kind of those from Black ethnicity feeling that they have to kind of convince their healthcare professional, those from an Asian background feeling only partially listened to by their healthcare professional. And similarly, these show, this is a question asked about to what extent do you feel your ethnicity has impacted your health experience, and for those, and you can see a significant difference from those who are from non-white backgrounds. Fourthly, intersectional pressures intensify this sense of isolation. And I suppose really what we're saying here is that gender, ethnicity, social grade all seem to layer this kind of additional pressure on migraine experience. Men fear this sense of emasculation, women fear being seen as overly emotional. In our quant survey, we asked for verbatim feedback, kind of open-ended questions around why do you think, you've said that you think that your age, your gender, ethnicity and social grade has impacted your experience. Why do you think that is? And we saw a lot of women saying, it's because I'm a woman, because I'm seen as being over emotional, because I'm seen as not being able to kind of cope. And people also talked really openly about these cultural norms and expectations of resilience, of silence, of self-sacrifice. Women talked about the kind of caring responsibilities that they need to be available for, and therefore they just had to kind of get on with it. And that sense, as I've kind of spoken about before, but I can't really stress it enough, is that particularly for those from lower socioeconomic groups, for whom employment can feel a lot more vulnerable, that kind of lack of a safety net made that sense of accessing support and that impact of kind of the stress and pressure of how will my migraine impact on my work life really, really acute. Finally, good support for people really is about belief space and peer connection. And I think what we heard most often in this work is not that people were saying, I want there to be like a wonder drug that's going to change my life. I think what people were kind of saying was, I just want to be believed. I want to be given a space where I'm trusted. I want to be given a space where people kind of understand what I'm experiencing, and I want time to kind of recover without guilt and not worrying that people are thinking that I'm being lazy or that I'm just not able to cope with something that should be fairly trivial. And just that sense of need of wanting to find a kind of community that and a space that just gave them quiet recognition and trust. So 5 core insights, and I come back to the kind of core point I made up front. This sense of, and I hope it's come through in the research, and I'm really happy to pick it up in the questions, but this sense of, I hope what you can see from that is that real sense that migraine has these significant impacts on your ability to interact with the world and your ability to be financially stable in that world, and your feelings of kind of security and being understood and being trusted, and this sense of how you feel that you are perceived by others, how you feel you will be supported, how you feel you will be trusted, how you feel you will be listened to, really impacts your sense of willingness to kind of disclose, and how people then receive you when you do has this fundamental impact on your sense of self. As part of this work, we've kind of worked with the Migraine Trust to kind of think about, okay, well, what would make a difference? And there feels like this kind of 5 thing. 1, to create spaces both in work, in home, and also particularly importantly in the healthcare settings where trust is the default, where people feel that they can disclose and that they will be trusted and listened to. The need for really tailored support that reflects people's real lived experience, that people feel that they are reflected and acknowledged within the work. The need to create kind of new social norms, I think, within society as a whole, where people feel that their own personal networks validate them and help them and inform them effectively. The need to create kind of safe and supported spaces, particularly at work and also in healthcare professional settings, that really create supported spaces for disclosure, and that there is a focus on those professions and spaces that for those who are in low socioeconomic groups and where there's a higher proportion of kind of non-white communities. And then finally, the need for, as I think that kind of final point I just talked about, the peer-led, identity-informed support, and that getting that right can be almost as beneficial as getting the kind of healthcare, the formal kind of healthcare experience right. And final thing to say is, I showed you a big a big expanse of blue at the beginning, which is how we felt really when we started looking at this work. And we've given you a boat, but there's a need for lots more of them. And this really feels like just the start. And what we need is to build on, as the community, to build on those foundations of building greater understanding, more supportive systems, better experience, and greater well-being. Thank you. I'll hand back over to Rob.
Phillipa, thank you. Thank you for covering what was a huge piece of research so nicely in terms of the key bits in a short space of time. And I hope all those who are here found it helpful and useful. And please, if you've got questions, please do ask them in the chat. Before we go to the panel, I'd love to invite Abigail to share your story. I think that's probably in some ways the most important bit. I think for me, it's I think the I can talk about data and impact till the cows come home, but I think it's the person with lived experience. It's the pin drop moment. It's the most important piece. And so just thank you again for your time and over to you. And thank you, Abigail.
Thank you so much, Rob. Really happy to be able to kind of share my story and my experience here. It's quite ironic listening back to a lot of the research that has been done, because I could literally see a version of myself within a lot of the things that were mentioned. So I was diagnosed with hemiplegic migraines about 10 years ago now, when I was 16. And yeah, it was really an interesting experience. I remember being in the doctor's office, went to see my GP after many appointments, and kind of being on treatment that wasn't really working for me. And at the time, I remember I had my GCSEs coming up, so I was really struggling because it was impacting my ability to be present at school. My teachers were questioning whether I was committed or studious enough when it came to my studies. My entire structure of life had changed. I wasn't able to attend like my sports events and things that I would usually do. So it was really tough. And I remember sitting in the doctor's office, and again, he kind of looked at me with this level of skepticism, and I could sense that he didn't really either understand or believe, or probably a mixture of both, what I was going through and the symptoms that I was presenting with. He couldn't grasp his mind around the fact that I've been feeling unwell for the last week, not able to get out of my bed, having difficulties mobilizing around even just my own home. He just couldn't grasp it. And I remember actually seeing the kind of pin drop moment for him when I was sat in the chair and I was getting up to leave his office after we had another conversation, and he didn't want to prescribe anything. And before I could even reach the door, I collapsed to the floor because my body could just not bear my own weight due to the pain and the discomfort. And that was the first time that I felt that my GP, whose care I'd been in for such a long time, actually understood and believed me for once. And unfortunately, this is the experience I had for the majority of my care under the NHS. As a young girl, being told by neurologists and specialists that, oh, well, you're still going through puberty, you might just grow out of this, or being questioned whether my symptoms are truly as intense as I was making them out to be. And these are like some of the many kind of conversations that we would have. And what really was frustrating for me is that I felt I didn't have any kind of partner or advocate who was trying to find a solution to this problem or find a way to make this more manageable. I often felt that I, as mentioned in the research, was in charge of my own management, of my own pain management, of my own, just management of the diagnosis overall. And oftentimes it felt like even if I did do all the right things, keep all the diaries, keep track of all the episodes, when I presented that information, there was no real concrete plan to follow up on that. And I think that also comes possibly partly from a lack of knowledge, especially when you're dealing with general practitioners, but even on the migraine field in general, amongst pediatricians. I've been on the pediatric care and then also like adult neurology. And that's somewhere where I was expected to become an expert myself, in essence, because that's the only way I was going to be able to figure anything out, which is really disappointing, right? Because ultimately, I've grown up with the NHS knowing that if there's anything wrong, this is my point of call. These are the people that are supposed to be here to help me in any kind of medical struggle that I'm having. And the ball was really dropped there. And not only did I feel not taken serious as a child, because some things are kind of put to, well, you're still growing, you're developing, you'll grow out of it. But particularly as a young Black girl and now a young Black woman, I felt that oftentimes there was a perception that my pain tolerance was much higher. I remember one of the first times I went into hospital, into A&E, just not knowing why I was presenting with the symptoms I was presenting. One of the doctors at the time actually threw out there that I could possibly be having a brain tumor, but I was dealing with the pain so well. That's obviously not something that you would want to hear. First of all, you don't want to hear that you have a brain tumor, but also that you're dealing with the pain so well, because actually that already gives a preconceived notion of how you are being perceived and the kind of care that you're going to get based off that. And also, I just felt like a lot of the times people trivialize my migraine down to, oh, you're just having a headache kind of thing. And that was not only within my care environment, it was within school and also within my workplaces. And that had a significant impact on how confident I was in who I am in these spaces, how I was able to present and show up in my work. So yeah, there's a very common thread where I believe, just as a Black woman, the perception of how you manage pain and how you deal with things is a default setting to almost resilience, which can be a compliment in many ways, but in this occasion, it does a lot more harm than good. So yeah, that's a little bit of a recap of my story and my experience so far. But I'm really keen to hear that this research is happening, and I think there is so much more work to be done. And I think also for me, why it's really important to share my story is because I've been working with the Migraine Trust for a few years, and I've had people who I had no idea that had a diagnosis or were struggling with this reach out to me and say, like, I never knew that I wasn't the only one facing this. I never knew that I was the only person dealing with like this kind of pain. And just having that kind of sense of community, that sense of relatability, it does really give you almost like a bit of this backbone to know that, yes, I'm not just like a crazy person who's imagining this all in their head. No, my experience is validated, and it's something that does, happen, and it makes you feel like you do have a place, which is quite differently from when you're sometimes speaking to a medical professional who might say, well, we see these cases 1 in 1,000, which can be very isolating even to hear something like this. So yeah, 100% really, really happy to see this research going on, and can't wait to see what comes out of it off the back of this. So yeah, thank you for letting me share my story.
Abigail, thank you. Thank you. It's just very generous of you to share, and I'll probably come back with you with some questions later on as well. So don't feel like you've escaped yet. Naren, if I could come to you, actually the first thing is, and you'll do this far more eloquently than me, and I should have done at the beginning, is there was a request in the chat for an explanation of what migraine is. But then be helpful if you could. I'd just love to get your thoughts on this research and thoughts about, I suppose, that what it means in terms of the NHS, maybe the lack of data that's around there, and is there anything in the NHS you feel could do to try and gather more data around this that could help us understand better and be more impactful with what we do?
Thank you, and thank you very much, Phillipa, and particularly Abigail also for sharing that very powerful story of your experience. I have to say, sadly, it's not the only time I've heard that, but it's important to to articulate that, because there's a lot of differential experience of migraine care across the NHS, depending on your socioeconomic or ethnic background. In terms of the question around migraine, I think Kate's put something in the chat, but obviously, hopefully everybody is aware, migraine is a very common, not rare, neurological disorder that affects between 15 to 25% of the population. In some studies could be much higher, because there's a study from Norway where they looked at neurologists, and 40% of all neurologists had migraine. That can't be because of neurologists, but probably that they're better at recognizing it. So it might be much more common than we think it is, according to research studies. The condition causes severe pain. Everyone recognizes that it causes a headache, but it is emphatically not just a headache. The headache is a symptom of a much broader neurological disorder in which there is a broader sensory hypersensitivity, sensitivity to light, sound, movement, and often other neurological symptoms, visual disturbance, sensory disturbance, in some patients, paralysis, loss of the ability to speak. Abigail was describing hemiplegic migraine, where you get weakness developing down one side of the body. So it's a complex neurological disorder, and the disorder itself needs to be treated rather than just the pain, and painkillers are not often the solution unless it's very infrequent and relatively mild. So that's the broader context. Being very common, I think it's also important to understand that this is a problem for everybody in the NHS. So about 4% of all GP consultations in the country are for headache. So that's a huge amount of healthcare resource. But obviously there's differential training, there's differential understanding amongst healthcare practitioners across the pathway about what migraine is and how best to manage it. And so I think my sort of first reflection, without sort of hogging the questions here, is that there are probably two elements that need to be focused on. One is the sort of healthcare profession, that's the sort of individual angles of raising awareness with the public, particularly in groups who have less awareness of migraine, and also raising healthcare awareness amongst healthcare professionals who are there at the first port of call, particularly in primary care and community services. The second point is actually about getting the systems right, because ultimately we all work in systems, and actually what we need to do is organise those systems to make it possible for the right care to be delivered easily, for education to be delivered routinely, so that we routinely get care right for patients, rather than relying on trying to individually train every single healthcare professional or every single member of the public in migraine. And there's obviously much more about workplace awareness in schools, and trying to address the lived experience of migraine for people, rather than just the sort of medical aspect of it, because obviously that individual is experiencing their pain and other neurological symptoms in a wider context.
Thanks, Naren. If I come to you, Phillipa, just thinking about the research, was there anything that particularly either, I guess, surprised you, or I guess you touched on, I guess, some of the early on, I guess maybe the possible gaps in terms of based on the data size, and so I'd fascinated to know what the surprise piece for you, and your thoughts on what good looks like next if wider pieces of research should be undertaken.
Yeah, thank you. I think two things really stuck out for us as a team. I think one was really in the workplace context, the how much I suppose the fear of discrimination and the kind of vulnerability that people felt around disclosure, and how strong that was. And we saw it in the quant work, it was really there, and we knew it. There is previous work that's been done that's talked about for migraine the challenge of presenteeism, so people showing up even though they're kind of in a position where it's much more challenging for them to kind of do the job that they're doing. So we kind of knew that, but I think that real fear of discrimination, and then so it came through in the quant, and then we saw it really clearly in the qualitative work with people who were in quite high risk roles, and being incredibly clear that there is no way that they would disclose what was going on for them because of the fear of losing the job, and what that would mean for them and what that would mean for their families. And I think that I wonder how much we have that conversation about, we might talk about working days lost, we might talk about that, but I wonder how much we talk about migraine in terms of the context of people's ability to remain in work, and the impact of them falling into poverty, and the kind of that piece. So that piece definitely kind of really struck us. I think the other thing that kind of really struck us, is the is the kind of the level of, I suppose, discrimination that people felt when they were within a healthcare setting. So, you know, you saw the stats that I sort of talked about people feeling that they weren't believed, or that they didn't, you know, they felt like they really were having to kind of convince the profession they were engaging with. As I said, in the verbatims that we saw in the open-ended questions, people talked about, you know, feeling like, why do you feel like you're dismissed? I feel like I'm dismissed because I'm Asian. I feel like I'm dismissed because I'm a Black woman and I'm perceived to have a higher pain threshold. I feel that I'm, so, you know, that kind of self-reported experience, I think, came through really strongly. So those are the things that I think are the kind of two of the really big takeouts. I think in terms of I think that there is a load more work that needs to be done to kind of get into the detail of this. I think that, like I said, this is a broad foundational piece that gives us a breadth, but now I think there's a need to kind of really look at specific communities and, you know, really think about like what is and to be able to work with those intersectionalities. So what is and how do those experiences differ in different places kind of across the country? So I think I'd really welcome people on this call to kind of encourage and to kind of think about what could happen. But I also don't think the answer is just research. I think we also need to do some really good, empowering, co-designed pieces of work to kind of build, you know, to kind of think about how do you create those much more trusting spaces, and how do you do those across different workspaces and in different healthcare settings.
Thanks, Phillipa. And just on that, I mean, the Migraine Trust is very keen. We want to work with organisations and to in terms of getting that deeper piece of work and understanding what this means for communities. And so we would love those who are a part of this to, you know, get in touch with us and to explore that. We feel it's a really important opportunity and part of the what's next piece, most definitely. Kate, can I ask you, the workplaces came out very, very, very highly. It was interesting. I suppose this piece of research originally we thought was all going to come out around about healthcare, and actually work came out quite high in terms of the challenges. What do you think needs to be done about trying to create that change in the workplace to better support people with migraine? I mean, there's the Migraine Trust perspective, but there's the wider piece, I think, as well.
Yeah, as Rob said, this work initially started focusing on the healthcare aspect, and actually work, as with often when we do research around migraine, workplace always comes out as one of the strongest places where people really feel that impact of living with migraine. And I think it's important to remember that for some people as well, migraine can be classed as a disability under law as well. And so when people are not getting that support in the workplace, that goes against that. It really shows that lack of understanding around migraine as a condition. And that's sort of at the crux of a lot of this, is that when people disclose migraine, they're often not taken seriously. They're often, as Rob shared before, they're often not given the support that they need and that they deserve. So a lot of the emphasis, especially with the government's move to getting more people into work and getting more people working, is about employers understanding that migraine is a condition that is worthy of discussion, worthy of people getting support for. It's a fluctuating condition as well, so someone can be fine for a month, for 2 months, and then they could have a really bad month, depending on how their attacks affect them as well. So it's sort of understanding how migraine does affect people and what it means. And a lot of it is around creating the safe space where people feel they feel that their condition is recognised, and also that they feel that they can talk about what they need, because across the board, we know that migraine isn't taken seriously in the workplace, let alone, as this research shows, if you're already feeling that you might be at a disadvantage if you, or a risk of potential discrimination if you disclose your condition as well. We've got lots of different resources on the Migraine Trust website for both employers and employees around sort of having that conversation. And we do want to obviously empower employees to feel able to have that conversation and raise what they need. But the emphasis really has to be on employers, because as we know, people are faced with a lot of different barriers to talking about their migraine in the workplace.
Thanks, Kate. And workplace is a key focus for Migraine Trust moving forward. not just through this piece, but wider as well. If we can improve workplace practices, clearly that the people who live with migraine are going to benefit enormously. Hopefully they're going to keep their job, they're going to have healthy, positive careers, but actually the colleagues will benefit from it, from understanding it, and I guess employers will benefit as well from happier, healthier, and more productive staff as well. So it's a big focus for the charity moving forward. Abigail, can I ask you, from your experience and just, I guess, from thinking about the data and the conversation so far, what do you think needs to change?
Oh, that's a great question. I think there's quite a few things that would need to change. I think when we look at the institution of the NHS on an institutional level, there needs to be looked at, okay, why do we consider certain people to have higher pain thresholds and not? And I think that also goes back a lot to the medical research that has been done. I think particularly in women's health as well, we're now seeing that actually we don't know a lot about women's health because there hasn't been research done specifically on women's bodies. A lot of our medical research is based on male anatomy. And I think that in itself, when we have fundamentally different systems, organs, hormone fluctuations, those things will impact exactly how conditions can present. So those are kind of like on the research and the institutional side. But I think also when we look at, this might be considered controversial, but I think when we look at the business that is behind healthcare now, we need to really reconsider what is our priority here. Are we looking at businesses that need to be running for profit or businesses that need to be helping people? And I think that is the very fundamental baseline of where changes can really be implemented. And I think also within the workplace, like mentioned by Kate just now, there needs to be a lot more education, and particularly in schools as well. I think actually schools have a great opportunity to be able to spot symptoms very early on and be able to support children in that, which is what I could have really benefited from. But the lack of knowledge and understanding in there, again, has that negative impact there. And I think that's a thread that kind of from younger ages then feeds into different phases of school, education, and then into the workplace. And I think that's where we could really see big changes if we kind of address it from the bottom all the way up to the top.
Thanks, Abigail. And you touched on important points there, and it was mentioned also in some of the questions around children and schools. The Migraine Trust commissioned some research a couple of years ago, which showed huge challenges around education. I think 75% of schools had no information or didn't know how to even support children. So I think it's a big piece of work moving forward. Liren, I didn't know there's anything from your thoughts on that in terms of, I guess, the schools piece, because I suppose there's a bit for me that thinks that if we can improve that bit in terms of children, young people, then and they're cared for and they're treated earlier and better, actually the outcomes when they're adults will be more improved as well. So that's one question. And then I'm probably going to throw another one, which is just thinking about, see, I'm very greedy. But thinking about where we are in terms of the 10-year plan and the push to, I guess, the left shift. What needs to be done at a local level, and is there a role that you see for the Migraine Trust can actually support the healthcare professional community, so they have the right information, so they can support their patients in the best way they can do?
Thank you. Very different questions. I'll take the first one though. I think the school point is broader for me. I think we spend a lot of effort in the NHS trying to solve the problem of migraine once it gets to the really severe end, where people have got constant headaches, off work all the time and requiring high cost treatments. But the vast majority of people in that situation wouldn't be in that situation if we'd actually identified the problem early on, started the treatment early on, supported them to live their lives well, and kept the condition under control. As many people in the room will know, that using painkillers too often will cause migraines to become far more frequent and significantly complicate the issue, for example. But people don't know that. Healthcare professionals don't know that. The public certainly broadly don't know that. So there's a really important piece about education early on. And given that migraine, particularly in women, tends to start around time of puberty, I think schools are clearly the place to start. I entirely agree with you. It's difficult to sort of work out the best way to do that through the NHS alone. I think it's linking through paediatric services into sort of wider education. But one of the things that often works well is piloting good models within broad governmental systems, local government systems, or a group of trusts within a foundation academy, for example, and seeing what the impact is on children living with migraine and really understanding what works well, so you've got best practice that can be shared. But I do think it's much more about trying to identify early on. I'll give a personal example. I think you've heard me say this before, but I am a doctor. I have migraine. Despite training in medical school, I didn't realise that the headaches I was having were migraine until I actually became a junior neurologist. And I didn't actually seek treatment for it until I became a consultant neurologist running a tertiary headache clinic, at which point the treatment changed my life completely. But I sort of failed, despite learning about it in medical school, I'd failed to recognise the diagnosis myself. And I think if that's the situation for someone who's a medically trained doctor, I think it's going to be much more common in the general population that people are under-recognising their health issues. Linked to that, we can come to that community left shift bit. So if we want to treat people well, we need to understand them within their context, within the communities in which they live, and try and support them really within primary and community services, because migraine is way too common for us to treat it as just a specialist problem. And so there is an opportunity around this neighbourhood health model and community care to try and get, for example, collectives of GP practices to work together to develop sort of expertise amongst some of the professionals within a group of practices, or develop community-based services. And then once you've got that expertise, it's easier for people to look at that wraparound care. I think my general experience is that GPs, in particular, and GPs with specialist interest, often are better at managing migraine than neurologists may be, because they have a wider view of the person's health and how other health conditions that they have might be impacting them. So I think all of that's really critical. And I think there's also a lot to link in with what Abigail was just saying about the different perception of pain amongst women, or certainly the Black community. There's a lot that is currently being done to address huge inequalities in treatment of pain for people living with sickle cell disease, which people will be aware only affects people of African Caribbean backgrounds. And there's huge evidence that the pain is routinely dismissed and not treated because of an assumption that people are able to cope with it or should be able to cope with it. So I think you can address that better if you've got areas where high ethnic minority populations, community-based services are going to be able to address that local need better than a centralised service in a tertiary hospital. So I think it's all about left shift really in terms of solutions.
Thanks, Naren. There is a real piece, isn't there? I think also about just raising public understanding of migraine, and that's sort of a more wider general piece, but also targeting, but as you mentioned, in communities. And I'm not going to ask you to look what's inside your back pocket, but I think there's in terms of the funding piece, but I think there's an opportunity, I think, for the charity to try and get some funding for, I think there's a real need for awareness campaigns around migraine. It's as you say, it's so common, and we need to educate the general public as much as health professionals about migraine. It's not just a headache, to go and have that conversation with a healthcare professional at a more general piece, but also particular groups, and try and understand what that conversation looks like for them as well. So again, that's something that I think we need to focus on next year. There's a little bit around, I guess, from my perspective, that we've seen really positive changes around mental health and around menopause, and it feels like migraine needs to be aspirationally looking there at the same time. There's some comments in the chat around workplace and the important shift around reasonable adjustments and that cultural shift. And I think that's something that the Migraine Trust is very much wanted to focus on next year in a more deeper level, doing some more deeper work with companies as well. We know that's very, very important at the same time. So, because there were 2 or 3 comments there, I just wanted to quickly touch on that, because I think we are close to the end now. I've just had a look, we're about 1.5 minutes to go. I would really like to thank all of you on the panel for your time and answering the questions. Apologies for those in the chat if your questions weren't answered. Please contact the Migraine Trust separately if there's ways that we can help, both personally, but also in terms of, I guess, your organisations and how maybe we could work with you at the same time moving forward. I think for me the important bit is this is just the start. I think the data here is important because there was no data before. So I think it's great that we've got this, and I think this gives us a starting point, but there has to be more research, more deeper research, more wider research to understand really what this means. And we're really, really keen, I think, to work with as many of you who are at this session to understand what that means, how you'd like to work with us, how we can have the very best impact we possibly can be as a group and all together. So lastly, just thank you again to the panel. Thank you for Claremont for running this research. Very valuable. Thank you for everyone for attending. As I said, please do get in touch with the charity if you'd like to work with us, or we can support you or people you know who live with migraine on a personal level as well. And enjoy the rest of your day. Thank you.